host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Good afternoon and welcome to our program. I am Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here. My first guest today, Dr. Michael Stuntz, fellowship-trained oncologic surgeon. Dr. Stuntz, thanks very much for being here.
You're welcome.
Dr. Stuntz, of course today we're going to talk about lymph node dissection. But first, before we get there, let's talk some more about this idea about fellowship training. Now, I know you're a general surgeon, and I want to define that for our viewers and our listeners. And then I want to talk about what fellowship training is. So again, let's talk about becoming a general surgeon. What do you mean by general surgeon?
Well, after you've completed medical school, you specialize in some area. And I specialized in general surgery, which involves going to a residency. So I start with a general year of an internship, where you learn about all different types of surgery, and then you specialize in general surgery. That takes 4 additional years. And then following that, you can specialize even further within general surgery into a variety of different specialties, such as vascular surgery, laparoscopic surgery, or oncologic or cancer surgery. And that's the fellowship I did, was an oncology fellowship.
So when you finished your training in general surgery, you were, by all intention and purposes, you were capable of going out and taking a job or going into private practice or taking even an academic position, and you could have worked as a general surgeon. Isn't that right?
Correct.
So you elected to do additional training beyond the regular general surgery training, and that fellowship or extra training, that was in oncologic surgery. Is that true?
Yes.
Okay, great. So let's talk about that. Now, how long was your fellowship?
Fellowship was a year.
A whole year of mainly doing cancer operations.
Yes, yes. Just specialized only in cancer operations and in teaching residents. Sometimes you would do some teaching and run clinics where you'd have a breast cancer clinic, say, where I would be in charge of it, and a colon cancer clinic where I'd be in charge of it. So you'd see the patients before and after surgery.
I see. So, Dr. Stuntz, isn't it true that if you're a fellow, say you're a fellow at an academic department or at a university that trains residents and medical students, it's almost like you're above the chief resident?
Yes.
Right?
Yes. Yes.
So what type of cases did you do during that year? What type of operations did you do during that year when you were training in oncologic surgery?
Well, if you can imagine it, we did it. There was all sorts of cancer operations. Anywhere in the body that you could have cancer, an oncologic surgeon would be responsible for taking it out. So most of the garden variety tumors were breast cancer, colon cancer, stomach cancer, esophagus cancer. So you'd be working within the trunk of the body, but then there'd also be extremity cancers like sarcomas, which are tumors of the muscle or the bone, and melanomas, which are tumors of the skin. And so you could take out a tumor in virtually any part of the body. And you'd learn how to do that, and various parts of the body have more nuances that you have to know to be careful of, structures that are dangerous if you injure them.
Right. So Dr. Stuntz, you being fellowship trained, you do offer some special expertise in cancer surgery and cancer operations.
Yes.
So again, let's just go over a capsule summary of your training. So after high school, it's 4 years of college,
Yes.
4 years of medical school, then you did a year of internship, then you did your general surgery residency, and that's how many years?
5.
5 years of general surgery residency, and then you went on after that and did a whole year of cancer surgery.
Yeah, I did 2 years of cancer research in there too.
Well, Dr. Stuntz, I tell you, I must admit that for a community of this size and the size of this county, we're very lucky to have a doctor with your training. And I appreciate you coming on the program.
Oh, thank you.
So, what we'd like to teach our audience today is about the lymph node and lymph node dissection, and there are a number of things that I want to talk about. I want to talk about what a lymph node is, and are they normal to have, or do we all have them, or is it a bad sign if we have a lymph node? And I want to talk about sampling them and radical lymphadenectomy and sentinel node dissection. So if we may, let's start with talking about the lymph node. Now, is it true that we all have lymph nodes?
Yeah, there's lymph nodes all over your body, thousands of them. And the lymph nodes are part of the lymphatic system. So when I'm talking to patients and explaining surgeries I have to do, I always take a step back and say, let's talk about what the lymphatic system is and how the lymph nodes interrelate to it and how you can identify those lymph nodes and why cancer might be there. And so the lymphatic system is a drainage system. It's like a sewer system is how I explain it. The artery brings the blood out to the cells, the veins bring it back, but the fluid that comes out and circulates around the cells to give them nutrients actually has to have a way to get back into the system, and that's called the lymphatic system. So these little tubes carry the lymph, which has both white blood cells and fluid and a variety of other things and proteins and such, and that circulates from the tissues into the lymph nodes. So every part of your body gets blood, every part of your body has lymph drainage, so there are lymph nodes responsible for every part of your body.
So, Dr. Stuntz, I remember as a kid, when I'd get a fever or a cold or something, my mom and dad would want to say, you know, I want to see if you have swollen glands.
Yeah, let me feel your glands.
Right. Now, isn't that true, that the so-called swollen glands, now those are lymph nodes?
Yes.
Right?
Yes, yeah.
Now, why do they get swollen when somebody gets the flu or a cold or the fever or fever or something? Why do they get swollen?
Well, that's their job. The lymph nodes are sort of the police stations or the filters of the system. So if you get an infection, the lymph system picks it up, and the lymph node actually captures that infection and creates a response to it. You make antibodies to the bacteria or the virus that you've been exposed to, and then that goes throughout your body and gets rid of that virus or bacteria.
Okay, so you said that throughout our bodies, the artery delivers the blood, right, from the heart. The veins return the blood, and there is that extra fluid, it's lymph fluid or serous fluid, that goes through the lymph system, and the lymph nodes are within that system. Is that right? So they're really part of our immune system.
Yeah, important part.
So if there's a dysfunction in the lymphatic system or in the immune system, then problems can spring up or occur with the lymph nodes. Is that true?
Sure. Yeah, like with lymphomas, lymph nodes get very large, and that's how you first even notice that you have lymphomas. You feel a bunch of large lymph nodes in an area.
I see. Okay, so let's talk about your job as an oncologic surgeon. Now, sometimes you're called upon to remove a lymph node, right, or even many lymph nodes. Now, why is it that we sometimes would want to remove a lymph node?
Well, the cancer sometimes travels via the lymphatic system. Cancers can spread throughout your body in several ways. They can directly spread into adjacent organs, or they can spread via the lymphatic system into the lymph nodes and then into the body, or they can spread via the blood system and go directly to like the liver or the lung. And so the lymph nodes actually act as a barrier to cancer, or as an area where that you can see that they've spread to.
Okay. Now I think this is important we want to teach our audience. I think this is important to emphasize, that we all have lymph nodes. Having lymph nodes is a normal part of being alive, right?
Everybody's got them.
Right. Everybody's got lymph nodes. And I think it's important to emphasize that just because certain lymph nodes get enlarged or even inflamed, it doesn't mean a person has cancer.
No.
Right?
That's true.
So lymph nodes can become enlarged. Let's say even if you hurt your hand or you cut your hand, lymph nodes in the armpit or even in the epitrochlear area might get enlarged. Is that true?
Correct.
Because they're responding to inflammation or an injury. Okay, so that's not, just because you can feel a lymph node get large doesn't mean there's a cancer.
Yeah, the vast majority of times when someone comes with a swollen lymph node in their arm, in their neck, on their groin, it's a benign process causing it.
Okay, so let's get back to removing a lymph node. Now, I think there's many different stages we can go through, or different types of operations that you go through to get the lymph node tissue. Let's start with, say, a simple lymph node sampling. Let's say, for example, a 50-year-old woman is sent to your office by the oncologist, and she has some palpable lymph nodes. By palpable, I mean lymph nodes that you can feel in the armpit, and the oncologist asks you to sample some nodes. Now, how do you go about that?
Well, in a woman, you'd be important to make sure she doesn't have a breast cancer first, so you'd want to make sure that there's no masses or lumps or problems on the mammogram in that breast. But assuming there isn't, then you would feel where they are, and you could surgically biopsy them in several ways. One is to put a fine needle into it, which is a tinier needle directly into the lymph node, and you can You can feel it easily. You don't need any particular guidance other than your hands. Or you could use an ultrasound to guide it into place. Or if it's a deep, trickier lymph node, you could even use a CAT scan to do a needle biopsy of it. The next bigger biopsy would be what's called a core biopsy, which is actually just a bigger needle that takes a bigger sample of the tissue. And then you could do a surgical biopsy where you go in and actually remove a piece or all of the lymph node.
Okay.
Most of the time with lymph nodes, I do a removal biopsy.
Okay, so typically a person or a patient with an enlarged, unusual, let's say persistently enlarged, growing lymph node, they will have some sort of biopsy. And we've talked about this in our program before. The biopsy process means we get some cells or tissue, and we let the pathologist look at it under the microscope.
Correct.
Is that true? Now, the pathologist can tell us if that lymph node is simply inflamed or infected, or if there's a lymphoma or a cancer of some other type. Now, isn't that right?
Yes, yeah. He'll look under the microscope and be able to identify the type of cell that you've removed and make sure it is from a lymph node, and then tell you whether it's benign or malignant.
Okay. Now, Dr. Stuntz, I don't mind telling the audience I'm very lucky enough to be able to work with you on many occasions. And in my office, I hear patients ask me oftentimes, well, if the lymph node system is part of our immune system, or they ask me if the lymph node is part of the immune system, isn't it harmful to the body to remove it? Like, don't we want the lymph node to be in the body?
Correct. Well, there's a lot of redundancy in that system, and so removal of a few lymph nodes or even all the lymph nodes in one area generally doesn't cause any long-term consequence. You can obstruct the flow of lymph through an extremity especially, and you might develop swelling, and that's a consequence of a more aggressive lymph node removal. But when you're just doing a biopsy of one or two lymph nodes, it's very rare I see any significant complication from that.
Okay, so certainly a 50-year-old woman with large, persistently large, palpable nodes in the armpit would be unusual, or something like a supraclavicular node. That could be unusual, right?
Yes.
If someone has a palpable lump just above
their collarbone.
Just above the collarbone, that would typically warrant an investigation or a workup. Isn't that true?
That's correct.
Now, would you typically, say, do a fine needle aspiration of that, or would you try to remove the node?
In the armpit, I might do a removal node or a core biopsy. Up higher in the neck, I would use a smaller needle to try to identify what it is.
Okay. So I want to move on to the concept of a regional lymphadenectomy, and then I want to talk about sentinel node dissection.
Okay.
So let's say that we have a 60-year-old man with a biopsy-positive melanoma of the thigh, for example.
Okay.
And we ask you to do a regional lymphadenectomy in the groin area or in that inner hip area.
Yes.
Now, how do you go about doing that, and why might you do that?
Yes. Well, if the melanoma has spread to the lymph node basin, and usually we would identify that with the sentinel node technique, or if he had a palpable lymph node in that area and you did a biopsy and knew there was already cancer in that basin, then you would want to remove it. And the reason behind that is that improves their survival. They will have a less likely chance of dying of melanoma if you take out those lymph nodes. In melanoma especially, it tends to get stuck in the lymph nodes before spreading to the rest of the body. It also is helpful to know how many lymph nodes there are and the type of invasion in the lymph nodes for guiding other therapies like interferon or chemotherapies. But how we would do it was we'd make an incision over the groin, and there's a specific triangle of tissue that the lymph nodes sit in, and we remove it within anatomic boundaries.
Okay, so Dr. Stuntz, I think that's important information, and I want to convey that to our audience. As I said, sometimes my patients ask me in the office, and I'm a plastic surgeon, they ask me, don't we want the lymph nodes to stay in the body because they're part of the immune system? But removing a lymph node or some lymph nodes can give us hugely valuable information, correct?
Yes,
and
also, save your life.
and also, if there is a cancer or if the tumor has taken root in the lymph node, we want to remove that, right?
Correct, yes.
Okay, so you mentioned making an incision. Sometimes the incision is quite extensive. You mentioned lymphedema in an arm, and that can also happen in the leg?
Yes.
Now, let's talk about lymphedema. Teach our audience about what lymphedema is or what that means.
Well, lymphedema means there's an impairment of the lymph drainage of the extremity. And so in the arm or in the leg, after you've removed a large number of lymph nodes, the flow of the fluid back to the system has been impaired, and so it can back up. And so the extremity will swell, and that's called lymphedema.
Okay, so which brings us to our important new development, a relatively new development that I know you've done a number of, and again, I have been very lucky to be able to work with you doing this technique, and so has Dr. Doug Sunday, another excellent plastic surgeon. That's what we call sentinel node dissection.
Yes.
And I see this as a real step forward, a real mark of progress in lymphadenectomy.
Yes.
Now let's talk about sentinel node dissection. What do we mean by that phrase?
Well, the word sentinel means guardian, or the lymph node that oversees that area. So if you have a melanoma on your hand, then we would want to identify the first possible lymph node that it would spread to. And this is true also in breast cancer. We do the same thing. So we identify in a special way where that lymph node is, we remove it, and then if it has cancer in it, most of the time then we will be removing additional lymph nodes there. If there is no cancer in it, then that saves many patients a removal of all the lymph nodes and the potential for lymphedema or other complications from bigger operations.
So that's excellent. So I see that as a real step forward. I mean, that's progress because we can remove a lymph node, we can get hugely valuable information, but we can minimize the downside with such things as a big incision, extensive scarring, and decrease the incidence of lymphedema.
Yes.
Isn't that right?
Yes.
So it's a huge step forward, and again, that's called sentinel node dissection. Now, Dr. Stuntz, we have about a minute left.
Okay.
Now, I want to let our audience know about your office, so if you have a phone number or a website.
Yes, Monterey County Surgical Associates, it's a website.
Monterey County Surgical Associates, and you are Dr. Michael Stuntz,
Yes.
S-T-U-N-T-Z.
Correct.
So, Dr. Stuntz, if a patient who's, say, listening or viewing, if they can feel a lymph node or a lump in their armpit or their groin themselves, should they call you directly? Do they go to urgent care? Do they see their family doctor? How's that work?
Well, in general, I would see my family doctor first for a lump that seems odd, because most of those tend to be nothing serious. And if it's growing in size or if it's painful, then that's a little more urgent situation. But I would still probably start with your primary care physician. If you've gotten to the point where you've seen them and they think that it needs to be removed or biopsied, then that's the time to see a surgeon.
Okay, Dr. Michael Stuntz, fellowship-trained oncologic surgeon. I certainly appreciate you coming on the program, and I hope you'll come back again.
I'll be happy to.
That's sentinel node dissection, Dr. Michael Stuntz. Thanks for being here.
Okay, thank you.
I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause. Thanks for being here.